Good morning. I'd just like to thank Dr. Tofi and Erbach for the opportunity to present this morning, and I have nothing to disclose. And when I was thinking about this topic, mesh overuse, I got the feeling this was chosen very deliberately to be a little controversial and provocative. So in thinking about how to discuss this, I decided to use this to kind of set up some of the other provocative talks to follow. But when you think about overuse, it suggests that there is a correct amount of use, right? If we're overusing something, somebody must be using it right. So to set that up, I'm going to talk real briefly, just quickly, about why do we even use mesh. This also implies we actually know how much mesh is actually being used in the US and abroad, whether we have good recommendations for mesh use, and how are we actually utilizing it. So let's talk about very quickly why do we even use mesh. And the rationale for mesh use is pretty well known, and a lot of it comes back to these landmark 2 papers out of the Netherlands, where a cohort of 200 patients were randomized to either suture repair with what we would now call probably the less appropriate technique of big bites and big suture versus a 2 to 4 centimeter onlay overlap, onlay or underlay overlap. And in the first follow-up at about 36 months, you can see that the recurrence rate was twice as high for the primary closure. And when this group was followed up again for a total of a 10-year follow-up, still we have unacceptably high recurrence rates, but it's twice as high in the suture group. So this was sort of the genesis of what got everything going. And when you look at some studies that review primary repair, tissue repair without mesh, they all have unacceptably high recurrence rates in ventral hernia. And when they calculated this out into a meta-analysis, you can see that using mesh is 60% less likely to cause a hernia, so it's protective. By the way, I love this bear. I love the fact that he's peeking in and he wants to know what we're doing in here, right? It's just so cool. So we can, I think, agree that primary repair of ventral and probably inguinal hernias has unacceptably high recurrence rates, and we tolerate mesh use because it significantly reduces the rate of hernia recurrence. All right, so how much do we actually know about how much mesh we're using, whether here or abroad? So we're the market, right? We're the ones putting this stuff in, but we're in the dark. Has anyone ever walked up to the exhibit hall and asked one of the vendors, hey, how much of this stuff do you guys actually sell a year? I'm sure they know, but everyone starts looking around, I'm not sure, I could email somebody, right? They're not gonna tell you how much we use. So if you try to use Dr. Google to find out, you'll get things like this, how we're a huge market, and for just the small fee of $5,000, they'll tell you what's going on, right? So we don't even have access to our own data on this. Here's another one, it's a little bit cheaper, right? $4,590. So none of us are gonna shell out for this, and who knows how good this data even is. So if we look at what's in our literature, one of the first papers was by Dr. Ira Rutkow in 2003, and even this was a guesstimate because he was using data from 1996 from a survey done of ambulatory surgery centers, and then he kind of made some assumptions about the growth. But you can see that his estimates in 2003 were that we were doing 770,000 inguinal hernia repairs a year. So inguinal's biggest number and lots of them. And when you add in the smaller hernias like femorals, umbilical hernias, epigastrics, that brings it up even higher. When you look at how the distribution of cases was done in 2003, you can see that mesh repairs were really the standard by that point. Tissue repairs were down to 7%. And we actually have, in looking at some other data, I'll show you a couple numbers in a minute, but how are we now possibly counting? So this paper looks at all of the active big registries for hernias, and really the only one that is the most useful is the Danish hernia registry, because they're capturing 100% of their hernia repairs. Sweden's pretty good too, and the rest are really voluntary, right? Even our AHSQC here, it's a small number of surgeons that it's capturing in terms of numbers. But if we look at inguinal hernias, at least, in Denmark right now, they're currently doing 100% mesh repairs almost, and in Sweden, that's pretty close as well. This was another study where they compared from 2010 to 2015 numbers from NISQIP, the Premier database, and Mayo data. And again, you can see that open repairs were the most common at that point, but lap was starting to grow. And some more numbers from the Millennium Research Group, which I think a lot of us saw about 10 years ago or so, but you can see that in the USA and Europe, again, inguinal hernias are the majority total. And I was kind of chatting with Ben Powlis about this, since he's kind of one of the brain trusts behind the AHSQC, and even Ben's like, yeah, I don't really know exactly how many we're doing here, so here's like a rough ballpark number. So we really don't know. This is some data from England and Wales, where they counted up over the course of a year how many different kinds of hernias that they were doing. And over 1 year, they did about 76,000. And again, inguinals far outstrip everything else. So how is mesh used? How do we use it? Because I'm lazy, not that I'm lazy, there are just too many papers out there, right? I mean, how are you gonna read every single paper? So we turned to people who did it for us, like Dr. Moisems, who I see in the audience, who has been on every single guideline that I pulled to look at, right? We look at guidelines. We look at people who sit down, pull the data together, and analyze it for us. So there's a number of guidelines, and we'll start with the inguinal hernia repairs. And pretty much from the get-go, people are saying the standard is to use mesh, right? Tissue repairs are reserved for very specific settings. And when we look at the Hernia Surge Group, which is an international group bringing together a whole bunch of different organizations in Europe and across the world, again, the use of non-mesh repairs, they're saying it's very specific, and that they only suggest it in the case where a patient absolutely refuses to have a piece of mesh. This is their algorithm. They don't really emphasize it on here, but you can see most of it is focused on the different kinds of mesh repair. One place where people do talk about using tissue repair still is in low resource settings. So in countries where they might not have access to mesh, the funds for it, or it can be potentially complicated if you operate on a patient in that setting and they get a complication. But even so, the recommendation is to help those low resource areas get access to mesh materials so that they have the same standard of repair as the rest of the globe. When the Asian Society got together to look at their recommendations, they were using the same data, so therefore they came up with the same recommendations, which was essentially to use mesh. There was a recent guideline put out for umbilical and epigastric hernias, which was a combination between the European and American group, and it asked straight out, is there a place still for sutured repair? And really, they felt like it was limited to very small hernias, 1 centimeter or less. Otherwise, it was felt that mesh is the right thing to do. And you can see that here in their algorithm, where this is the only spot where they're recommending a possible sutured repair, that 0 to 1 centimeter hernia. When the International Society looked at the same question, initially, they talked about doing primary repair for 2 centimeter hernias, but when they followed that up, they dropped that down to 1 again as well. So as we have more data, the standard really is to use mesh for most repairs. All right, finally, how much are we actually utilizing mesh? How can we overuse something if we don't know how much we're using it? So in this study, which was done in the VA population, in 2008, they looked at about 16 different VA hospitals, and they found that mesh was used about 70% of the time, but that there was significant variation in how the mesh was used, and it wasn't really patient-based, it was more facility-based, suggesting that there were cultural reasons that mesh was being used differently. Another study looked at the trends of inguinal hernia repair, and I found this really interesting. You can see here that in the late 90s, that solid line is open non-mesh repairs. And in the early or late 90s, 94% of the inguinal hernia repairs were tissue-based. But by 96, that dropped down to 40%, and in 08, down to 4%. So those Bassinis really went down as both laparoscopic and open repairs picked up. And that's just a little bit of a look at how the mesh was being used in open hernia repairs between a plug and patch in Liechtenstein. So finally, what are we doing here now? And the Michigan Surgical Quality Collaborative, I think, is the group that probably has the best handle on this. So they looked at an initial study where they took their hospitals within their quality collaborative for a year, and they looked to see how mesh was being utilized in different hospitals. And they saw that when hernias were small, mesh was being used about 53% of the time. And when hernias were large, at least 10 centimeters, mesh was being used 95% of the time. I'd be interested to know what they did in the other 5%. And mesh was most commonly being used as a sublay. And at this meeting here, they actually updated this data, and Ryan Howard and Dana Tellem were kind enough to let me reshare their data, which I think is really interesting. So when they looked again over a 2-year period at these 65 hospitals, which included over 4,000 patients, they found mesh was used about 78% of the time. And at a patient level, as the size increased, the use of mesh was more likely to be involved. So you can see that with minimally invasive repairs, hopefully you would have mesh all of the time. But with the open repairs, it definitely was on a curve as size increased. But what's fascinating is they found that at a hospital level, there was no correlation between the size of the hernia and the approach. So you would expect to see those red dots of the minimally invasive approach and the blue dots of the hernia width track with the percentage of mesh use at each hospital. But it's widely variable. There's really no effect that they could find, and the use of mesh varied between hospitals between 38 and 96% of the time. So their takeaway was that the results suggested there was a significant amount of arbitrary practice and variation between hospitals in the management of ventral incisional hernias, and that we have a lot of opportunity to align our practice with evidence and guidelines. So I put in very small print, are we using mesh enough? So how does this talk fit in with the others? Well, the objectives here were to look at the evidence and about mesh and to talk about the complications. My conclusion is that our actual data on mesh utilization is hard to find. It's behind paywalls. Actual data on how we as surgeons use mesh is hard to find. And it's really hard to know if we overuse mesh, underuse mesh, or do we even use it correctly at all? So I think what we need to focus on is the right mesh in the right location as part of the right procedure. And that's not necessarily overuse. Thank you.